Hello and welcome to Psych Reads. This is Gina. Today I'm going to be reading through the book The Gift of Therapy by Dr. Irvin Yalom, MD. This book is subtitled An Open Letter to a New Generation of Therapists and Their Patients. In this video, I'm going to be reading the back summary of the book, and I'll be reading also the introduction. Starting with the back summary. The culmination of master psychiatrist Dr. Irvin Yalom's more than 35 years in clinical practice, The Gift of Therapy is a remarkable and essential guidebook that illustrates through real case studies how patients and therapists alike can get the most out of therapy. The best-selling author of Love's Executioner shares his uniquely fresh approach and the valuable insights he has gained, presented as 85 personal and provocative tips for beginner therapists, including let the patient matter to you, acknowledge your errors, create a new therapy for each patient, do home visits, almost never make decisions for the patient, and Freud was not always wrong. A book aimed at enriching the therapeutic process for a new generation of patients and counselors, The Gift of Therapy is an entertaining, informative, and insightful read for anyone with an interest in the subject. A bit about the author. Irvin Yalom, MD, is the author of Love's Executioner, Mama and the Meaning of Life, Lying on the Couch, The Schopenhauer Cure, and When Nietzsche Wept, as well as several classic textbooks on psychotherapy, including The Theory and Practice of Group Psychotherapy, considered the foremost work on group therapy. Professor Emeritus of Psychiatry at Stanford University, he divides his practice between Palo Alto, where he lives, and San Francisco, California. The Gift of Therapy, An Open Letter to a New Generation of Therapists and Their Patients, by Irvin Yalom, MD. Introduction. It is dark. I come to your office but can't find you. Your office is empty. I enter and look around. The only thing there is your Panama hat, and it is all filled with cobwebs. My patient's dreams have changed. Cobwebs fill my hat. My office is dark and deserted. I am nowhere to be found. My patients worry about my health. Will I be there for the long haul of therapy? When I leave for vacation, they fear I will never return. They imagine attending my funeral or visiting my grave. My patients do not let me forget that I grow old. But they are only doing their job. Have I not asked them to disclose all feelings, thoughts, and dreams? Even potential new patients join the chorus and without fail greet me with the question, "Are you still taking on patients?" One of our chief modes of death denial is a belief in personal specialness, a conviction that we are exempt from biological necessity and that life will not deal with us in the same harsh way it deals with everyone else. I remember many years ago visiting an optometrist because of diminishing vision. He asked my age and then responded, 48, eh? Yep, you're right on schedule. Of course, I knew consciously that he was entirely correct, but a cry welled up from deep within. What schedule? Who's on schedule? It is altogether right that you and others may be on schedule, but certainly not I. And so it is daunting to realize that I am entering a designated later era of life. My goals, interests, and ambitions are changing in predictable fashion. Erik Erikson, in his study of the life cycle, described this late life stage as generativity, a post-narcissism era when attention turns from expansion of oneself toward care and concern for succeeding generations. Now, as I have reached 70, I can appreciate the clarity of Erikson's vision. His concept of generativity feels right to me. I want to pass on what I have learned, and as soon as possible. But offering guidance and inspiration to the next generation of psychotherapists is exceedingly problematic today because our field is in such crisis. An economically driven healthcare system mandates a radical modification in psychological treatment, and psychotherapy is now obliged to be streamlined, that is above all inexpensive, and perforce brief, superficial, and insubstantial. I worry where the next generation of effective psychotherapists will be trained. not in psychiatry residency training programs. Psychiatry is on the verge of abandoning the field of psychotherapy. Young psychiatrists are forced to specialize in psychopharmacology because third-party payers now reimburse for psychotherapy only if it is delivered by low fee, in other words, minimally trained practitioners. It seems certain that the present generation of psychiatric clinicians skilled in both dynamic psychotherapy and in pharmacological treatment is an endangered species. What about clinical psychology training programs, the obvious choice to fill the gap? Unfortunately, clinical psychologists face the same market pressures, and most doctorate-granting schools of psychology are responding by teaching a therapy that is symptom-oriented, brief, and hence reimbursable. So I worry about psychotherapy, about how it may be deformed by economic pressures and impoverished by radically abbreviated training programs. Nonetheless, I am confident that in the future, a cohort of therapists coming from a variety of educational disciplines, psychology, counseling, social work, pastoral counseling, clinical philosophy, will continue to pursue rigorous postgraduate training and, even in the crush of HMO reality, will find patients desiring extensive growth and change, willing to make an open-ended commitment to therapy. It is for these therapists and these patients that I write The Gift of Therapy. Throughout these pages, I advise students against sectarianism and suggest a therapeutic pluralism in which effective interventions are drawn from several different therapy approaches. Still, for the most part, I work from an interpersonal and existential frame of reference. Hence, the bulk of the advice that follows issues from one or the other of these two perspectives. Since first entering the field of psychiatry, I have had two abiding interests: group therapy and existential therapy. These are parallel but separate interests. I do not practice existential group therapy. In fact, I don't know what that would be. The two modes are different not only because of the format, that is, a group of approximately 6 to 9 members versus a one-to-one setting for existential psychotherapy, but in their fundamental frame of reference. When I see patients in group therapy, I work from an interpersonal frame of reference and make the assumption that patients fall into despair because of their inability to develop and sustain gratifying interpersonal relationships. However, when I operate from an existential frame of reference, I make a very different assumption. Patients fall into despair as a result of a confrontation with harsh facts of the human condition, the givens of existence. Since many of the offerings in this book issue from an existential framework that is unfamiliar to many readers, a brief introduction is in order. Definition of existential psychotherapy. Existential psychotherapy is a dynamic therapeutic approach that focuses on concerns rooted in existence. Let me dilate this terse definition by clarifying the phrase dynamic approach. Dynamic has both a lay and technical definition. The lay meaning of dynamic, derived from the Greek root dynasthai, to have power or strength, implying forcefulness or vitality, to wit, dynamo, a dynamic football runner or political orator, is obviously not relevant here. But if that were the meaning applied to our profession, then where is the therapist who would claim to be other than a dynamic therapist? In other words, a sluggish or inert therapist. No, I use dynamic in its technical sense, which retains the idea of force, but is rooted in Freud's model of mental functioning, positing that forces in conflict within the individual generate the individual's thought, emotion, and behavior. Furthermore, and this is a crucial point, these conflicting forces exist at varying levels of awareness. Indeed, some are entirely unconscious. So existential psychotherapy is a dynamic therapy that, like the various psychoanalytic therapies, assumes that unconscious forces influence conscious functioning. However, it parts company from the various psychoanalytic ideologies when we ask the next question: what is the nature of the conflicting internal forces? The existential psychotherapy approach posits that the inner conflict bedeviling us issues not only from our struggle with suppressed instinctual strivings or internalized significant adults or shards of forgotten traumatic memories, but also from our confrontation with the givens of existence. And what are these givens of existence? If we permit ourselves to screen out or bracket the everyday concerns of life and reflect deeply upon our situation in the world, we inevitably arrive at the deep structures of existence, the ultimate concerns, to use theologian Paul Tillich's term. 4 ultimate concerns, to my view, are highly salient to psychotherapy: death, isolation, meaning in life, and freedom. Each of these ultimate concerns will be defined and discussed in a designated section. Students have often asked why I don't advocate training programs in existential psychotherapy. The reason is that I've never considered existential psychotherapy to be a discrete, freestanding ideological school. Rather than attempt to develop existential psychotherapy curricula, I prefer to supplement the education of all well-trained dynamic therapists by increasing their sensibility to existential issues. Process and content. What does existential therapy look like in practice? To answer that question, one must attend to both content and process, the 2 major aspects of therapy discourse. Content is just what it says, the precise words spoken, the substantive issues addressed. Process refers to an entirely different and enormously important dimension, the interpersonal relationship between the patient and therapist. When we ask about the process of an interaction, we mean, what do the words and the nonverbal behavior as well tell us about the nature of the relationship between the parties engaged in the interaction? If my therapy sessions were observed, one might often look in vain for lengthy, explicit discussions of death, freedom, meaning, or existential isolation. Such existential content may be salient only for some, but not all, patients at some, but not all, stages of therapy. In fact, the effective therapist should never try to force discussion of any content area. Therapy should not be theory-driven, but relationship-driven. But observe these same sessions for some characteristic process deriving from an existential orientation, and one will encounter another story entirely. A heightened sensibility to existential issues deeply influences the nature of the relationship of the therapist and patient, and affects every single therapy session. I myself am surprised by the particular form this book has taken. I never expected to author a book containing a sequence of tips for therapists, yet looking back, I know the precise moment of inception. 2 years ago, after viewing the Huntington Japanese Gardens in Pasadena, I noted the Huntington Library's exhibit of best-selling books from the Renaissance in Great Britain and wandered in. 3 of the 10 exhibited volumes were books of numbered tips on animal husbandry, sewing, gardening. I was struck that even then, hundreds of years ago, just after the introduction of the printing press, lists of tips attracted the attention of the multitudes. Years ago, I treated a writer who, having flagged in the writing of 2 consecutive novels, resolved never to undertake another book until one came along and bit her on the ass. I chuckled at her remark, but didn't really comprehend what she meant until that moment in the Huntington Library when the idea of a book of tips bit me on the ass. On the spot, I resolved to put away other writing projects, to begin looting my clinical notes and journals, and to write an open letter to beginning therapists. Rainer Maria Rilke's ghost hovered over the writing of this volume. Shortly before my experience in the Huntington Library, I had reread his Letters to a Young Poet, and I have consciously attempted to raise myself to his standards of honesty, inclusiveness, and generosity of spirit. The advice in this book is drawn from notes of 45 years of clinical practice. It is an idiosyncratic mélange of ideas and techniques that I have found useful in my work. These ideas are so personal, opinionated, and occasionally original that the reader is unlikely to encounter them elsewhere. Hence, this volume is in no way meant to be a systematic manual. I intend it instead as a supplement to a comprehensive training program. I selected the 85 categories in this volume randomly, guided by my passion for the task, rather than by any particular order of a system. I began with a list of more than 200 pieces of advice, and ultimately pruned away those for which I felt too little enthusiasm. One other factor influenced my selection of these 85 items. My recent novels and stories contain many descriptions of therapy procedures I found useful in my clinical work, but since my fiction has a comic, often burlesque tone, it is unclear to many readers whether I am serious about the therapy procedures I describe. The gift of therapy offers me an opportunity to set the record straight. As a nuts and bolts collection of favorite interventions or statements, this volume is long on technique and short on theory. Readers seeking more theoretical background may wish to read my texts, Existential Psychotherapy and The Theory and Practice of Group Psychotherapy, the mother books for this work. Being trained in medicine and psychiatry, I have grown accustomed to the term patient, from the Latin patiens, one who suffers or endures. But I use it synonymously with client, the common appellation of psychology and counseling traditions. To some, the term patient suggests an aloof, disinterested, unengaged, authoritarian therapist stance. But read on. I intend to encourage throughout a therapeutic relationship based on engagement, openness, and egalitarianism. Many books, my own included, consist of a limited number of substantive points and then considerable filler to connect the points in a graceful manner. Because I have selected a large number of suggestions, many freestanding, and omitted much filler and transitions, the text will have an episodic, lurching quality. Though I selected these suggestions haphazardly and expect many readers to sample these offerings in an unsystematic manner, I have tried, as an afterthought, to group them in a reader-friendly fashion. The first section, 1 through 40, addresses the nature of the therapist-patient relationship, with particular emphasis on the here and now, the therapist's use of the self, and therapist self-disclosure. The next section, 41 through 51, turns from process to content and suggests methods of exploring the ultimate concerns of death, meaning in life, and freedom, encompassing responsibility and decision. The third section, 52 through 76, addresses a variety of issues arising in the everyday conduct of therapy. In the fourth section, 77 through 83, I address the use of dreams in therapy. The final section, 84 through 85, discusses the hazards and privileges of being a therapist. The text is sprinkled with many of my favorite specific phrases and interventions. At the same time, I encourage spontaneity and creativity. Hence, do not view my idiosyncratic interventions as a specific procedural recipe. They represent my own perspective and my attempt to reach inside to find my own style and voice. Many students will find that other theoretical positions and technical styles will prove more compatible for them. The advice in this book derives from my clinical practice with moderately high to high functioning patients, rather than those who are psychotic or markedly disabled, meeting once or less commonly twice a week for a few months to 2 to 3 years. My therapy goals with these patients are ambitious. In addition to symptom removal and alleviation of pain, I strive to facilitate personal growth and basic character change. I know that many of my readers may have a different clinical situation, a different setting with a different patient population, and a briefer duration of therapy. Still, it is my hope that readers find their own creative way to adapt and apply what I have learned to their own particular work situation.